Hello, Dilushi.
Hello.
Hi. I'm Dr. Suranta. Shall we give a few minutes, 1 or 2 minutes for the more
Yes.
medical students to join?
Sure. Can I just make sure that I can be heard because it started
Yeah.
raining?
No, you are nicely
Is
heard.
it clear?
No issue at all.
Oh,
Yes, very clear.
Thank you. Thank you.
Can be heard, can be seen. Okay.
Thanks.
Yeah, Dilushi, I think more than 105 participants are there. So we'll start, Dilushi. I'm Dr. Suranta, Vice President, Sri Lanka Medical Association. I like to welcome all the medical students and any other postgraduate trainees who are joining today to Saturday's talk. Today the lecture will be given by Dr. Dilushi Vijayaratna, who is a consultant nephrologist at Clinical Medicine Department, Faculty of Medicine, Colombo. And she will talk about approach to acute kidney injury. I'm thankful for her for accepting our invitation and kindly agreeing to do the lecture today. Over to you, Dilushi.
Thank you very much. Thank you very much for inviting me to do this lecture today. It's a real honor. And thank you to all the students who have made the effort to come and listen to the lecture. I'll just share my screen. And I have to apologize. It's raining and there's a bit of thunder and lightning. So if you can't hear me at any point, just let me know. Can you see my slides?
Yes, can be seen, Dilushi.
Okay, thank you. So today's lecture is about the approach to acute kidney injury. AKI is one of the commonest problems encountered in the hospital setting. And you can see AKI in about 5 to 10% of general admissions, 20 to 25% of patients with sepsis, and over half of the patients who go on to develop septic shock. Again, over 50% of all ITU admissions may have acute kidney injury. Now, acute kidney injury is associated with an increase in in-hospital mortality and future CKD. It is very common, but often it's not the primary illness when patients get admitted, but rather it is a marker of the severity of whatever primary illness brought them to hospital. So, for example, if they have had a pneumonia, they can get AKI as a consequence of the pneumonia rather than because of a primary kidney problem. And the more severe the pneumonia is, the more likely severe the AKI would be in that particular patient. So when we talk about approaching AKI, there are two main aspects that I'm concentrating on. One is the diagnosis and the other is the management. And you'll realize that one cannot be done without the other. So they both go hand in hand. And AKI is a bit of a medical emergency. So while we are diagnosing what's going wrong with the patient, we also have to institute our management. So let's look at a case scenario. Think of a 70-year-old man with type 2 diabetes, osteoarthritis, and hypertension, who is admitted with an acute coronary syndrome and left ventricular failure. His pre-admission medications are metformin, atorvastatin, and diclofenac sodium with osteoarthritis and losartan. So when he is examined, his blood pressure is his pulse rate is 80 per minute, his blood pressure is 150/90, JVP is elevated, and he has bilateral fine basal crepitations on lung examination, which suggests pulmonary edema, and he has pitting ankle edema. So somebody very clever happens to be looking after him, and they do a serum creatinine, which is a measure of kidney function. So on admission, his serum creatinine is 1.3, and on day 2, his serum creatinine has gone up to 1.8. So what complication has arisen? Is this related? So let's just try to remind ourselves, what is AKI? Acute kidney injury is a syndrome resulting from a rapid reduction in glomerular filtration rate, which occurs over hours to days. So the fact that it is rapid is what we mean when we say acute kidney injury. And when we say it's a syndrome, we mean that it is just a manifestation of many, many things that can be going on. So for example, we say anemia is a syndrome, it is not a diagnosis. Similarly, AKI is also a syndrome. Once you detect it, we need to find out why it's happening. So how do we define AKI? How do we know what is a significantly rapid reduction in GFR? So the group called KDIGO, who formed the guidelines for the management of kidney disease, have come up with a definition, which is a rise in serum creatinine of 0.3 milligrams per deciliter in 48 hours, or a 50% increase in serum creatinine from baseline within 7 days, or a reduction of urine output to less than 0.5 milliliters per kilogram per hour for 6 hours. So there are creatinine-based criteria for diagnosing AKI, and then there are urine output-based criteria as well, right? Sorry. You will see this change of 0.3 milligrams per deciliter might seem to you to be a very, very small amount, and yet it constitutes a diagnosis of acute kidney injury. Now, all AKIs are not the same, so we stage them according to severity. And how do we assess severity? Again, by creatinine and urine output criteria. So AKI is staged into 3 categories, stage 1, 2, and 3, and 1 is least severe and 3 is the most severe. So 1 is where you will find your creatinine rise of 0.3 milligrams per deciliter, or 50% above the baseline, right? Or the urine output criteria that we discussed before. And then as these changes become more severe, the staging and the severity of the AKI is worse. So you don't really need to know the definitions of all of these, but you have to understand that even small changes can constitute an AKI. And the worse that these changes are, the more severe the kidney damage, the more likely the patient is going to need dialysis, and the worse the outcomes of the patient, right? So do these small changes in creatinine really matter? Yes. So even stage 1 AKI is associated with a 4-fold increase in the risk of hospital mortality. So that does not mean that patients are dying of kidney injury, right? It means that whatever brought them into hospital was so severe that apart from everything else, it also caused an AKI. So these patients are more ill than patients who don't develop AKI. So how do we know that a patient has acute kidney injury? So you'll appreciate these small changes in creatinine are not going to be clinically significant or clinically apparent, rather. So often these patients are asymptomatic. And you will only detect it if you notice a rise in creatinine. Or sometimes we have urea if you are not doing creatinine, but nowadays we all measure serum creatinine, right? Or if there's a reduction in urine output. So we know the criteria. If they are present, then the patient has acute kidney injury. But sometimes in late stages, we don't need to look at the urine output, or before we see the creatinine report, we know the patient has AKI. Why? Because they may have symptoms or they may develop complications such as uremia. So if patients are uremic, they may have nausea, vomiting, they may become confused. They can get fluid overload because their kidneys are not filtering properly. So then they get edema, and that can even be in the lungs, in which case it's pulmonary edema. They can have electrolyte imbalances. So mainly their potassium is what we are worried about. They can get hyperkalemia, and they can get metabolic acidosis. So AKI in its least severe form can be asymptomatic, right? But in its most severe form, it can be life-threatening and symptomatic. So here are a few learning points. AKI can often go missed in its early stages if it is not suspected. And AKI can occur even if the serum creatinine appears to be in the normal range. So always look at the baseline. So for example, if you think of a small maid woman coming into hospital, her creatinine on admission can be 0.5 milligrams per deciliter. And let's say it goes up to 1 milligram per deciliter. So it is still within the normal range. If you don't look back through the records and see what the baseline is, you will miss that she has had acute kidney injury. And why is it important to know? Because we need to look for anything that can be causing this and correct it, right? So that's one reason why we need to detect AKI. Also remember that in patients with better baseline kidney function, small changes in serum creatinine will indicate a worse renal insult. So you might think, okay, this lady's creatinine has gone up from 0.5 to 1. It is AKI, but her kidney function is still normal. So why are we worried? We are worried because she has lost 50% of her GFR, right? So whatever damage that has occurred has been a serious insult. So your creatinine going up by 0.5 milligrams per deciliter when your baseline is 0.5 is much more significant than it going up by 0.5 milligrams per deciliter when your baseline is around 4 or 5, right? Also remember, healthy patients have what is called a renal reserve. So the insult is even more than a 50% loss of GFR, okay, in this particular case. And if we miss early AKI, we may lose an opportunity to prevent serious harm. So sometimes you see patients who are started on particular medications in hospital, say aminoglycosides, they are notoriously nephrotoxic. And we miss these early stages of AKI because we don't realize that even though the creatinine is in the normal range, it's rising, right? So if we don't pick that up, we don't stop the drug, and therefore the patient can get severe AKI and even need dialysis. So small interventions can make big changes to the patient outcomes if we intervene in a timely way. Okay, so we know what AKI is. Now we need to know to look for the cause. So what are the causes of AKI? The causes of AKI can very usefully be divided into 3, right? Whatever happens before the kidney, what happens in the kidney, and what happens after the kidney. Pre-renal, intrarenal, and post-renal. So pre-renal is something that relates to the perfusion of the kidney, because if the kidney doesn't get blood, then it can't work properly, right? Post-renal means what happens beyond the kidney. So if the kidney, even if the kidney is working fine, if it gets obstructed, then the back pressure can affect the kidney function. And then finally, intrinsic kidney damage, which is where your nephrologist becomes particularly involved. So let's look at that in a bit more detail. So you can see here, acute kidney injury has been categorized into 3. So when we talk about pre-renal AKI, we are thinking of causes which affect the effective circulating volume. Effective circulating volume is going to determine your arterial blood flow to the kidney, right? So if your total circulating volume has dropped, or if your total blood volume has dropped because of hemorrhage, you can have hypertension and AKI. If you are dehydrated for whatever reason, again, you can get AKI. In some instances, you have too much water in your body, you are edematous, but your effective circulating volume is low. For example, in heart failure, you can have edematous, but your forward perfusion can be low. Same thing can happen in cirrhosis, nephrotic syndrome, right? Because of low intravascular volume. So in these cases, if it is severe enough, patients can develop AKI. Also, AKI can occur in a pre-renal way at the level of the glomerulus, because we know that glomerular filtration depends on the hemodynamics of the glomerulus. So certain drugs, for example, can affect the filtration, like ACE inhibitors and ARBs or NSAIDs. So ACE inhibitors and ARBs, they are very good for the kidney, right? But they can affect the glomerular hemodynamics. And therefore, they can make the GFR drop. So in the acute setting, when a patient is unwell, they reduce the kidney's ability to auto-regulate and maintain the GFR. So they can make AKI worse. If we quickly look at the post-renal causes before moving on to intrinsic renal causes, generally for you to have a manifest AKI, you need both kidneys to be affected. So you need to have either bladder outlet obstruction or bilateral ureteral obstruction, something affecting both sides. If you have only one functioning kidney, or if you have CKD, which means you don't have any kidney reserve, then even if one kidney is affected, you can get an AKI. Okay. So intrinsic kidney injury is very important, and that is where more specific interventions into the kidney itself come into play, right? So when we think of intrinsic kidney damage, it's again good to look at it anatomically. So it could be something that affects the vessels in the kidney, then the glomeruli, the tubules, and the interstitium, right? So if we think of the vessels, things that can affect the vessels are things like vasculitis, thrombotic microangiopathies, and hypertensive emergencies, which also cause thrombotic microangiopathy. So it can happen both ways. Then in the glomerulus, it could be an acute glomerulonephritis. So acute glomerulonephritis, when it's very severe, it can cause a rapidly progressive glomerulonephritis where the patient loses GFR very quickly, right? Then it can be something which affects the tubules or the tubular interstitium. So when we think of the tubules, the main pathology is acute tubular necrosis. And acute tubular necrosis is generally either ischemic or nephrotoxic. And of these two, ischemic ATN is the commonest. So of all the causes of intrinsic AKI, the commonest cause is ATN, and of ATN, the commonest cause is ischemic ATN. So how does this happen? It occurs because of a severe or prolonged pre-renal insult, right? So if the patient has low blood pressure for long enough, then the tubular cells become injured. And even after you restore the blood supply, the kidney doesn't work properly until those tubules are regenerated, right? So that is ischemic ATN. Toxic ATN is where some particular toxin acts on the tubules and damages them. And then again, that particular insult needs to be removed, and with time, the tubules can regenerate, right? So these toxins can be either endogenous or exogenous. Endogenous means they come from within the body. So it could be from red cells, which are lysing, hemoglobinuria, or myoglobinuria. Myeloma casts can cause interstitial nephritis. So though they put it under ATN here, it's more of an interstitial nephritis. And also crystals. So for example, certain drugs can cause crystal deposition in the kidney, which can be nephrotoxic. And then there are nephrotoxic exogenous agents. So for example, contrast and drugs, like I mentioned, aminoglycoside. So that is ATN. And then, of course, acute tubular interstitial nephritis is another entity. Again, you can have tubular interstitial inflammation as opposed to injury or necrosis, which is often due to drugs, but can occur due to infections like leptospirosis, or can occur in certain autoimmune diseases, and again can occur with certain crystal depositions. Okay. So whenever you have a patient with acute kidney injury, you have to consider all of these possibilities, because you have to remember, particularly in these patients who are, multimorbid, and coming in with AKI in the setting of another illness, the AKI is often multifactorial. So you have to look into the possibility of any of these contributing. Right. So often AKI is multifactorial, and looking for the cause of AKI is like being a detective. Your clues are in the history and in the urine. So let's look at a case. We have a 70-year-old man with diabetes, osteoarthritis, and hypertension, our friend from the case before. He's on metformin, diclofenac sodium, and losartan, admitted with acute coronary syndrome and left ventricular failure. So our questions are now, okay, this AKI could be multifactorial. So is there a pre-renal cause? Could there be an intrinsic renal cause? And could there be a post-renal cause? So if we think of pre-renal causes, he's just had an acute coronary syndrome. So could he have some problem with the perfusion to the kidney? So this could be either forward perfusion or it can be congestion. Both of them can affect the glomerular filtration. His blood pressure appeared to be normal, at least when it was measured on admission. He may have had hypertensive episode earlier. We don't know. We don't know what his usual blood pressure is like, but probably not much higher than 150/90. But he did have a high JVP and he did have edema. So probably congestion can be affecting the GFR. So there probably is a pre-renal cause. He's also on losartan. He's also on diclofenac sodium. So we know he's not able to auto-regulate his renal perfusion, right? So these also may be worsening his AKI. Could there be an intrinsic renal cause? Well, there could be, right? Of course, he has a diagnosis of acute coronary syndrome. So on top of that, would he have another intrinsic cause? It's possible. He's on diclofenac sodium. And of course, he can get some other illness. And of course, we have to ask ourselves, is this really an acute coronary syndrome or is it something else, right? And could there be a post-renal cause? So he's a 70-year-old man, right? His creatinine was 1.3 when he came in and it rose after admission. So it's not uncommon for these patients to develop urinary retention when they are in hospital, particularly because he may have some background prostate enlargement, right? So there could be a post-renal cause and we shouldn't miss it because it is something that is easily correctable. Right. So whenever we are managing these AKI patients, remember it's an emergency. So while we are thinking, we are acting as well. And diagnosing and management go hand in hand. So what should we do? We have to stop anything that's nephrotoxic, look for and correct the pre-renal causes. So we looked at the blood pressure, we looked at venous congestion. If there's congestion, we can give diuretics. Is there tract obstruction? So we look to see if the bladder is palpable. If it's palpable, we have a clear answer, but sometimes we need to go a step further and do a bladder scan. And maybe even another step further and do an ultrasound scan of the kidneys. So the probability of this being, some other kind of stone disease is a bit unlikely, but, if you don't come up with a cause, then that is something you need to do. And always ask yourself, are there any other suspects? Like, has he been taking any Ayurvedic medicine, for example? The important thing is to look for and correct all reversible causes. Because if you don't do that, then you are going to get into worse trouble later on. So just a bit of detail about playing detective. What might you expect if you have pre-renal, renal, or post-renal AKI? So in pre-renal AKI, if there's volume depletion, it's usually quite obvious. There may be decreased skin turgor, tachycardia, hypotension, low JVP. If there's cardiac pump failure, there might be an elevated JVP with hypotension. If there's sepsis, the patient might have warm peripheries with a bounding pulse, low JVP. And importantly, if the problem is pre-renal, then the urine should be bland because the kidney is normal. If the problem is renal, right, what might you find? If it's something affecting the vessels, there might be features of macrovascular disease. If there's a thrombotic microangiopathy, you might have low platelets. That's on investigation. And if it's a hypertensive emergency, you will have very high blood pressure. If it's a glomerulonephritis, you might have some features in the history and the examination which give you a clue to glomerulonephritis. So a common thing which we see in pediatrics and sometimes among diabetics is post-infectious GN. So is there recent skin sepsis or even ongoing skin sepsis, any skin rashes or hemoptysis or other features of Small vessel vasculitis, if you have features of small vessel vasculitis elsewhere in the body, you could have it in the kidney as well. Are there features of connective tissue diseases? Is there hypertension, again, which can be a feature of a glomerular problem, and edema? And then the urine can show an active sediment. So if the glomerulus is inflamed, it can become leaky. So you can get proteins, you can get red cells, and you can importantly get red cell casts in the urine and dysmorphic red cells. So those indicate a glomerular problem, which is why the urine is so important in an AKI. If it's a tubulointerstitial disease, is there any cause that you can find from the history? So any infections, any drugs, autoimmune diseases that you can think can be the culprit cause. And sometimes, particularly in allergic interstitial nephritis due to drugs, patients can have fever and rash, which is not that common, but if present would be very suggestive. So in the urine, you might be able to see white cells, which may be white cell casts even, and eosinophils. For postrenal, you might have a history of stones, you might have a history of LUTs, lower urinary tract symptoms. Patient might have hematuria, and the bladder may be palpable. So usually postrenal, again, you're not going to see features of glomerular inflammation or tubulointerstitial inflammation. So you won't see red cells and casts or proteinuria. So usually it is bland unless there is a superadded lower urinary tract infection. Okay, so that's how, those are some of the information that you can use to try to find out the cause of the AKI. Right, so what are our goals? Now we are trying to diagnose what's going on, but we're also trying to manage the patient, help the patient get better. So we have some priorities. We want to keep our patients safe. We want to keep our patients' kidneys safe, and then we want to treat any other complications and continue with the rest of the management. So if we look at keeping the patient safe, why are we worried about acute kidney injury? Right? Because patients can die of AKI. And how does this occur? The two main emergencies are pulmonary edema and hyperkalemia, right? And also metabolic acidosis if it is very severe. So pulmonary edema, if it's in a situation where the patient is in a life-threatening, has a life-threatening degree of pulmonary edema, it will be obvious, right? But hyperkalemia, you may easily miss it if you don't look for it. So you have to check it. And a venous blood gas is probably the quickest way to get a result, right? So it's not enough to just send the blood test. You also have to trace the report and see whether it is safe, right? Because patients can die of hyperkalemia. So what about keeping the kidneys safe? One question is this a renal emergency? So now we were saying a lot of things, there are a lot of causes of AKI, so pre-renal AKI, post-renal AKI. We are worried about all of these, right? But there are some instances where time is nephrons. That means that you have to be really quick in your management. And if you are delayed, the consequences to the patient are worse, are much more severe, right? And two of these instances are rapidly progressive glomerulonephritis and if there's a thrombotic microangiopathy. So if there's an RPGN, the kidney function can be knocked off irreversibly very, very quickly, right? So you have to act fast. Similarly, thrombotic microangiopathies also can have disastrous consequences within a very short period of time if you don't intervene quickly. So how do you know that it's either an RPGN or a thrombotic microangiopathy? There were some clues that we discussed earlier. RPGN is basically a most severe form of acute glomerulonephritis. So any cause of acute glomerulonephritis can cause an RPGN if it is severe enough. So always look at the urine. An active sediment could be an RPGN. So you have to refer to nephrology early. And nephrologists, if they suspect an RPGN, might want to start the patient on high-dose steroids, provided there is no ongoing infection or other contraindication. Okay? So what you can see in the corner there at the bottom of the slide are red cell casts. So if you see red cell casts and the rest of your clinical picture is also compatible, then you would diagnose and treat RPGN pending a renal biopsy because you don't have time to wait for the result of the renal biopsy. Another important thing is in a patient with low platelets, look for red cell fragmentation on the blood picture. to see if there's an ongoing thrombotic microangiopathy. And that needs urgent treatment, which may include plasma exchanging, depending on the cause. So keeping this patient safe is also about not doing any harm to the patient, right? So always you need to go through the drug chart. Sorry about that spelling mistake. Go through the drug chart. Look to see if there are any nephrotoxic drugs and stop them if there are any. And adjust the drug doses for the GFR. Some drugs you can't give when the GFR is low, not because they are nephrotoxic, but because the drugs become toxic when the kidney is not working, right? So it's impossible to remember all the nephrotoxic drugs, and it's impossible to remember all the dose adjustments. So we need to use a formulary. And remember that your eGFR equations cannot be used in AKI because the patient is not in a steady state. So those are all for chronic kidney disease. In AKI, if you measure the serum creatinine while the patient is going into AKI, you will get an overestimate of the GFR. So for example, if my kidneys stop working now, my creatinine may be normal. It takes time for the creatinine to rise, right? So you'll understand then that using the creatinine to estimate the kidney function is not quite correct. Similarly, when the patient starts to recover, the opposite happens, right? So there's no real equation that we can use to calculate the GFR in AKI. So often we go by the overall picture, and the urine output is generally a good guide. So what investigations do we need to send in these patients? Reminding ourselves about the mix between diagnosis and management. We've already mentioned some of these. We always want to do a urinalysis. The only reason not to do a urine test in a patient with AKI is if the patient is not passing any urine. Otherwise, a urine analysis is a must because we need to know if there's intrinsic kidney damage or not, right? Then we want to do a serum creatinine to know the stage of the AKI. How bad is it? A full blood count will help us to find the etiology sometimes, right? We need to do a serum potassium because we want to make sure that it is safe. A bicarbonate because, again, we want to see whether the patient has developed acidosis. Calcium and phosphate, they can be deranged in AKI. They are more likely to be deranged if there's CKD. And sometimes the changes can give us a clue as to the diagnosis of behind the AKI. And we always like to do an ultrasound scan to see if there's obstruction, to make sure that there are two kidneys, and to look at their sizes. So one problem that we face is differentiating acute kidney injury from chronic kidney disease. And the easiest way to do this is if the patient has a previous creatinine report. If the patient's creatinine was clearly normal 1 month ago and now it has risen into an abnormal level, then this is clearly an AKI, right? If the patient has urine reports from 6 years ago, for example, which shows heavy proteinuria on a background of diabetes, and the creatinine is abnormal now, we may be more likely to think that this is CKD. But remember, patients with CKD also can get AKI, right? The next best test is an ultrasound scan. So if the kidneys are very small and shrunken on ultrasound, then this is CKD. Is the CMD lost? That also suggests that it's CKD. Remember, in diabetes, you can have normal-sized kidneys, so that is not always helpful, but the CMD loss will be there. Are there risk factors for CKD? So if it's a diabetic, hypertensive, elderly patient, stones, patient on nephrotoxins, again, it's possible that this patient has CKD. But of course, there are plenty of patients who have these risk factors but don't have CKD, right? And if there are existing complications of CKD, again, that is helpful. So if there's anemia or bone disease, it could be CKD. If there's severe kidney disease, or rather if the creatinine is very high and none of these are there, then it is less likely to be CKD. So for example, if you have a patient coming with creatinine of 8 and the HB is 12, then it's much more likely to be AKI. So the history is still the best clue, right? So because anybody with CKD can get AKI. And a new reduction in urine output is almost always acute kidney injury. So the patient is coming to you with a problem. If the problem is reduction in urine output, then this is an AKI. Now, what about doing renal biopsies? We talked a lot about basic investigations that you do in AKI to diagnose the cause and to identify the complications. One important investigation is a renal biopsy. Why would we do a renal biopsy? Mainly when we don't know the cause of AKI. So we know the majority of AKI is pre-renal, another significant proportion is post-renal. So we're left with a small amount, maybe 10 to 15% of AKI where it's intrinsic renal. And of these intrinsic renal, again, often we know the cause. So often it is ATN, which is ischemic. Sometimes it's ATN because of a drug that we know is the cause of the AKI, and so on. So there'll be a very, very small proportion. And often it's these patients with glomerular nephritis or tubulointerstitial nephritis, but we don't know the cause. And that's when we would want to do a biopsy. And we are only going to do a biopsy really if we think it is going to change the management. So if somebody has, for example, a history of a cellulitis 2 weeks ago, now has an AKI, it may be glomerular nephritis due to a post-infectious GN. So doing a biopsy isn't going to really change the management because the management is generally conservative. So often we will wait. But if the patient is not recovering, then we ask ourselves, is this something else? Would we want to treat with something else if we found a different diagnosis on the biopsy, in which case we would do it, right? So there are not many indications for a renal biopsy in AKI, and often the guiding principles are if we don't know what's going on and if the biopsy result is going to change the management. Sometimes we do it when we want to prognosticate. That means, for example, if the patient has had, say, a snake bite, and the patient is taking a long time to recover, and we don't know whether this is ATN or whether this is something worse than ATN, like renal cortical necrosis, then we can do a biopsy to see, right? So the idea is that then we can plan the future management. So we can say, okay, if there is renal cortical necrosis, you're unlikely to come off dialysis. So this is going to be a long-term management plan. Whereas if it's ATN, we could say there's still time, there's still hope to recover, in which case you'd wait and see what happens. So we only biopsy if we think there's intrinsic kidney disease. There's no point in biopsying if you are suspecting a pre-renal or a post-renal problem. Right, so those were investigations, and now we are moving on to complications. So hyperkalemia, we have detected it because we were trying to keep our patients safe. And here is an ECG that you might see in a patient who is hyperkalemic. You can see that there are tall, tented T waves. And as the hyperkalemia becomes worse, the patient can get loss of the P wave, widening of the QRS complex, and even go into asystole. So what should we do in patients who are either prone to develop hyperkalemia or already have hyperkalemia? They should avoid a potassium-rich diet. They should avoid ACE inhibitors, ARBs, NSAIDs, or spironolactone, any drug that can make the potassium go up. So it's important to go to the drug chart and stop all of that and avoid potassium in IV fluids, right? And then if there are ECG changes or the potassium is over 6.5, we need to acutely lower the potassium. Why is that? Because they can get arrhythmias and they can go into cardiac arrest, right? So the fact that there are ECG changes means that even if the potassium is less than 6.5, they are already at risk, right? And if the potassium is more than 6.5, then they are at high risk. So therefore, every patient needs an ECG and a serum potassium level. Now, if you have hyperkalemia, you need to bring the potassium down very quickly, right? It's like sweeping the dust under the carpet, right? So you don't have time to actually clean the house properly, but you just need to sweep the dust under the carpet until you can sort out the problem more leisurely. Right? So what do you have to do? The first thing is you have to give IV calcium gluconate. So that actually doesn't lower the potassium, but it stabilizes the myocardium until you can lower the potassium. And then to lower the potassium, you hide the potassium elsewhere. So you give soluble insulin with dextrose, or you nebulize with salbutamol to hide the potassium within the cells. Now it won't stay there for long, right? So after a few hours, it'll be back in the circulation. So this is just to buy time until you can do something else. And that something else is either the kidneys are recovering on their own, or sorry. So the something else that you need to do is either the kidneys will recover on their own and then the potassium will come down, or your other interventions to lower the potassium will take effect. And these other interventions are to actually get potassium out of the body, right? So soluble insulin dextrose with soluble insulin with 50% dextrose and salbutamol will hide the potassium. Sodium bicarbonate, which is given if the patient has acidosis, will also hide the potassium, but will also help to get some of the potassium out of the body. But the main players in getting potassium out of the body are either your gut, your urine, or your dialysis, right? So for anything that you want to get out of your body, not just potassium, remember it has to go either through the gut, the urine, or through dialysis. So how can you get rid of it through the gut? Through potassium exchange resins. How can you get rid of it through the urine? Through diuretics. And the last form of treatment, if none of these work, is renal replacement therapy, right? The second problem is pulmonary edema. So how do we manage pulmonary edema? Just as you would under normal circumstances, nurse the patient propped up, give the patient oxygen, morphine. If the blood pressure is high, you can give GTN. And the mainstay here is furosemide. So furosemide is going to cause pulmonary vasodilatation, right? And also help with diuresis. So pulmonary edema in the setting of AKI is because of fluid retention. So you need to get rid of the fluid. And if you can get rid of the fluid with furosemide, then you don't need to go for dialysis, right? But if that is not working, if your kidneys are not responsive to furosemide, then you will have to go on to give the patient dialysis. And in the meantime, until you can arrange your dialysis, you might have to support with CPAP or even intubation. Okay. All right. So metabolic acidosis, you would treat with sodium bicarbonate. And if it is refractory to treatment, again, you would have to give renal replacement therapy. Right. So we can do some amount of symptom management. If there's nausea, vomiting, we can give antiemetics. But, nausea and vomiting are signs of uremia. So generally, if patients have these signs or symptoms, we would think of offering renal replacement therapy, particularly if they are not showing signs of recovering soon, right? And definitely indications for renal replacement therapy would be if the patient is becoming drowsy, has seizures, or has uremic flaps. Right. So let's talk a little bit about renal replacement therapy. So remember, it's not a cure for AKI, right? So it's only a bridge until the kidneys either recover spontaneously or by your specific intervention. And there are different modalities that you can use in acute kidney injury. You can use intermittent hemodialysis. So you may be familiar with that, like you give intermittent hemodialysis in CKD. You can give the same therapy in AKI. You can do peritoneal dialysis, right? Or you can do continuous renal replacement therapy, which is given generally in the ICU. So it's continuous as opposed to intermittent hemodialysis. So the patient is attached to the machine throughout the day, right? Now, what modality you use will depend on the availability, right? So a CRRT generally would be in an ICU setting. You cannot do hemodialysis if you don't have access to hemodialysis. Peritoneal dialysis, if you have human resources, you can generally do in even a low resource setting. So the main determinant of what you will use is availability, but continuous therapies are preferred in hemodynamically unstable patients, right? So if patient's blood pressure is low, they will not tolerate intermittent hemodialysis, in which case you can offer them CRRT, right? So when do we actually offer patients renal replacement therapy? It's when our medical management is not effective in managing the complications. Because remember, it's not going to cure the AKI, right? So it's only going to help us manage the complications. So refractory hyperkalemia, refractory pulmonary edema, refractory metabolic acidosis, and uremic encephalopathy, uremic pericarditis. So there's no specific blood test, blood of kidney function, like a blood urea or creatinine level at which you would initiate RRT, right? And there's no benefit from dialysis before traditional indications arise. So people have, done trials to see whether starting dialysis early before these indications arise is going to lead to better outcomes, and they have not, right? But a useful approach is to observe the trend. So we don't really want to wait until our patient with AKI develops uremic encephalopathy to dialyze them, because then we have created an emergency and then we are managing the emergencies. We want to be a bit more proactive. What we can do is observe the trend. And if we see that the patient is not passing urine or has very poorly or rapidly worsening kidney function, isn't likely to recover, then before one of these complications arises, but we are expecting these complications to rise before it becomes an emergency, we can initiate dialysis so that, the patient's life is not at risk. So we have to be a bit practical. Right, so the patient on RRT, here are some tips about managing patients on RRT. When patients are on renal replacement, their serum creatinine cannot be interpreted, right? So it doesn't really have much meaning. And a lower PhD, of course, may be a sign of recovery. So you can't really interpret the creatinine, but if you notice that the creatinine is coming down before the dialysis creatinine is coming down, it may be that they're starting to clear creatinine from their kidneys. Patients on dialysis, the best sign of improvement is the urine out, right? The patient who is anemic is now starting to pass urine. That shows that the patient is recovering, not the serum creatinine coming down, because serum creatinine could be coming down because of dialysis itself. And also remember that some drugs are cleared by dialysis, right? So just as you are removing toxins, drugs can also be removed. Therefore, they may need to be dosed or redosed after hemodialysis. So again, it's not possible to remember all the drugs which are removed by dialysis, right? You need to use a formulary. Right, so a little bit about the recovery. What happens in the recovery phase? So patients start to pass urine, and that is one of the most joyous moments when you are a nephrologist, is seeing a patient who is anuric starting to pass urine. And they may go through what is called a polyuric phase, where they start to pass lots of urine, right? And if they're not taking enough fluids, that can lead to dehydration and vicious cycle or delayed recovery from AKI, right? And also when they are losing a lot of urine, a lot of volume, they can lose a lot of electrolytes as well along with that. For example, potassium, magnesium, and calcium. So it's important to monitor these in the recovery phase. Right. So a few take-home messages from my lecture. Acute kidney injury is common. Even small degrees of AKI are associated with worse early and late outcomes. You need to have a high index of suspicion when you are dealing with patients with AKI to detect AKI. And the history is really the best clue to the diagnosis. You have to do urine analysis in AKI. Look for and correct any reversible causes. Check the serum potassium, right? Because unless you check it, you will miss it, and it can be a life-threatening emergency. Refer to a unit with renal replacement therapy if you expect it might be needed. And refer to nephrology if you suspect intrinsic kidney disease. So thank you, and I'm happy to take on any questions. I think there were some questions already in the chat. So someone has asked, are NSAIDs contraindicated in CKD? I would say yes, they are. So we generally don't want to give NSAIDs to patients with CKD because we want to avoid nephrotoxins. What is the place of oral salbutamol in managing hyperkalemia? So I have never used oral salbutamol. I don't think it's recommended. One of the advantages of salbutamol actually in these patients is that it can be given by nebulization. So you don't need IV access. And some of these patients, particularly, if they've got a bit CKD, they can, some of these patients, if they have CKD, they may have very difficult IV access. So in an emergency situation, it's a very useful thing to be able to nebulize the patient with salbutamol. I hope you notice that the dose of salbutamol that you use is much higher than what you would give in asthma, right? It's 10 to 20 milligrams. What is the fluid management in the recovery phase? So generally, I mean, there's no strict rule about fluid management. You would, in the first stage, you would like to replace the volume that is being lost, right? But later on, you would try to cut down on how much you're giving. So you're not going to give the entire volume because, again, that is going to set up another cycle where your patient is losing whatever you are giving, right? So sometimes we start by replacing volume to volume. And then after that, we come down proportionately, maybe 75% replacement and so on. And then according to thirst. Management. So I'm not sure what this question refers to. Is the management the same for pediatric patients? So the approach would probably be the same, right? Some of the disorders, the diseases may be different, and the specifics of managing those diseases, but otherwise the principles are pretty much the same, I would say. Does HCT cause hyperkalemia? HCT causes hypokalemia. So someone has asked about chronic renal replacement therapy. So that's not, as you have also suggested, it's not really related to this topic. The indications are, of course, the same, right? What type of resources do you need to do peritoneal dialysis? So peritoneal dialysis, I mean, it's something that you do in a low resource setting. The resources that you need people who know how to do it, right? So you need you need to be able to insert a PD catheter, and it's not something that requires a lot of skill, but you have to be trained to do it. And then you need to have access to PD solutions, and then a nurse who can conduct the peritoneal dialysis. So it doesn't require a lot of training, right? So and it's not like a hemodialysis where you need a separate unit. You need a water supply for hemodialysis, then you need expensive machines. So none of that infrastructure is necessary for peritoneal dialysis. Is it safe to give Lasix? I hope you can hear me. It started raining again. Is it safe to give Lasix in congestive cardiac failure and pre-renal AKI? Yes, it is safe. So in fact, now if you're thinking of congestive cardiac failure as the cause of pre-renal AKI, right? Congestion is one of the main reasons for why the kidney is not working properly, because the venous pressure is so high that there isn't enough forward pressure into the glomerulus, right? So the only way to relieve that is actually by decongesting the patient. So yes, you should give Lasix. So Lasix is not nephrotoxic. There's no point in unnecessarily giving Lasix to patients just to have a urine output, because you are not going to gain anything. It's not going to cure the AKI, right? The indication is if they are fluid overloaded. So if they are fluid overloaded, you can give them Lasix. And in this particular setting, where the overload itself may be worsening the AKI, it may be helpful. When should we omit ACE inhibitors or ARBs? That's a really good question, and it's quite controversial also. Some people say you shouldn't omit ACE inhibitors or ARBs in AKI. I think one instance where it's very useful is in pre-renal AKI, because we already said that pre-renal AKI, that ACE inhibitors and ARBs, they affect the autoregulation of the kidney. So under normal circumstances, if you're not on an ACE inhibitor or an ARB, if you are hypervolemic, your kidney is able to respond to that by, appropriately constricting your afferent and efferent arterioles. and maintaining the GFR. But if you're on an ACE inhibitor or an ARB, you can't do that. So in people with a pre-renal AKI, would generally make sense to stop the ACE inhibitor or the ARB. Also, I think it's quite practical to stop it in AKI because hyperkalemia itself is an indication for dialysis. And if patients, become hyperkalemic on the ACE inhibitor or the ARB, it's just a waste of everybody's time, effort, and a high risk for the patient. So I would generally stop both of these, and the strongest place is in pre-renal AKI, but it's an area which is still a bit controversial. So someone has asked about aspirin in CKD. So no, generally we don't have concerns about aspirin worsening CKD. Is furosemide the only diuretic we can use in AKI? So generally, so lots of diuretics don't work if your GFR is not good enough, but furosemide is one of the diuretics that does work at a low GFR, right? So furosemide we would use. Thiazide diuretics wouldn't work alone in low GFR, but we can use them on top of a loop diuretic if we want to achieve a higher diuresis. You might have seen that we add metolazone to furosemide sometimes when we want to manage the fluid. We generally wouldn't use spironolactone again for the reasons of hyperkalemia. So in our urologic clinic, we see a lot of patients with normal baseline creatinine presenting with rising creatinine with unilateral ureteric obstruction. These patients improve with unilateral stenting. What's the reason for this unilateral obstruction and rising creatinine? So one theory is that when you have a stone on one side, you can get spasm in the ureter on the other side. So that's just a theory. I don't know how true it is, but that can be one explanation for why someone with a stone on one side can get a rise in creatinine. The other possibility is that there's some sort of, now we're all talking about renal reserve. So maybe the creatinine at baseline is normal because the patient, because even though the patient has lost some reserve, it's still not manifest in a rise in creatinine. And then when the kidney gets obstructed, because the reserve is already lost, maybe it becomes apparent as a rise in creatinine. Are ACE inhibitors contraindicated in AKI? I think we have answered that question. What are the determinants you mentioned to differentiate AKI and CKD by urinalysis? So you can't really differentiate AKI from CKD by a urine test, right? So AKI, by definition, is a change in the GFR over a very short period of time, right? So if you have an active sediment, that can indicate both AKI or CKD. It just tells you what kind of pathology is going on in the kidney. If you do have an active sediment, you're more worried that this can be AKI, but it doesn't differentiate between the two. So could you explain in what extent Ayurveda drugs affect AKI? So I'm not able to give you a list of Ayurvedic drugs that cause AKI, but some herbal therapies, for example, we've seen quite a lot of cases of starfruit toxicity. So starfruit is taken by patients to lower their blood glucose, and then they can get interstitial nephritis because of oxalate deposition in the kidney. And like that, there are other ways in which these drugs and other therapies can cause acute kidney injury. So some other things are vitamin C, vitamin D. So we saw lots of patients on these treatments during COVID, right? So they are not without harm, even though they are vitamins. They can also cause kidney injury. Is an ultrasound a must in AKI? Not always, right? So if the cause of AKI is obvious, then it's not necessary, and it's a waste of resources to really ask for an ultrasound in everybody with an AKI, right? So it's if you think that there's obstruction, if things are not, so if you think there's obstruction, definitely. If there's no clear diagnosis, definitely. And if the patient is not recovering the way that you expect the patient would recover, then again, it would be indicated. And always, if you're doing a biopsy, you should have an ultrasound before. In the absence of ECG changes, can we wait till serum potassium is more than 6.5 for hyperkalemia management? Yeah, you can. So that is what the guideline says. The problem is getting the potassium report, but yes, ideally you should, right? So these drugs are also not without harm. So remember, insulin can cause hypoglycemia, and these patients are more prone to hypoglycemia with insulin because they are not able to clear the insulin, right? So you shouldn't really treat unnecessarily. 50% dextrose is, it can cause thrombophlebitis, right? And these are patients who might go on to need long-term renal replacement therapy. So we want to preserve their vascular access as much as possible. So, so you don't have to do the acute management, right? But you do need to do the other things before it comes to the point where you need acute management. So even at 5.5, you stop all your ACE inhibitors, ARBs. You would start the patient on furosemide, correct any acidosis, start Calbind and lactulose. Generally, I suppose you would, though the guidelines say 6.5, I would generally start acute management at 6, partly because it's really difficult to get a serum potassium level done on time, right? But 5.5 to 6, I don't think it's necessary. Does rapid serum creatinine rise, is rapid rise in creatinine an indication for RRT? No, so that's what I was saying. So there's no serum creatinine cutoff for starting dialysis. You dialyze according to those indications that I mentioned. So furosemide, I hope I've covered that. So furosemide you use if the patient is overloaded. It's not nephrotoxic. It's a useful drug. Any drug can be nephrotoxic, but I wouldn't worry too much about furosemide-induced nephrotoxicity. What are your thoughts about fluid and furosemide challenge? I don't really, I'm not really a fan of giving furosemide and fluid at the same time. I think the furosemide challenge could be useful for you to really know that the kidney is working and kind of prognosticates. If the patient is not responding to a furosemide challenge, then that tells you, okay, this patient is not going to recover soon. So the patient might need dialysis. So you can plan in that setting. But otherwise, it's not something I would generally do. Do we continue CRRT until improvement of urine output more than 0.5 milliliters per kilogram per hour? So no, not necessarily. Generally, what happens when patients are on CRRT is that they're quite practical about it. So CRRT circuits are short-lived. So once the CRRT, if the patient is not recovering and the circuit clots, then of course we continue it. But if the patient has been starting to pass urine, usually we continue it until the circuit clots. And then after that, we reevaluate whether the patient needs it or not. So it's not just the urine output. Also, we look at the other parameters as well. And also remember that CRRT started generally because the patient is hemodynamically unstable. So if the patient does become stable, it's much more convenient for us to switch them on to HT. And then, once the indication is over, we can stop the hemodialysis. With low GFR CKD patients could use ACE inhibitors, yes. So now we even use, not only now, we use ACE inhibitors even in patients who are on dialysis because they have other benefits. So one thing is they can preserve the residual renal function, right? So that has some value even in a patient on dialysis. It's better for them if they're able to pass urine because for whatever reason, they seem to live longer, right? And also often these patients have other comorbidities. So they might have ischemic heart disease, they might have heart failure, so they may have another indication for being on an ACE inhibitor or an ARB. So yes, we would continue the ACE inhibitors in CKD. What is the time demarcation for AKI and CKD? So generally, the definition of CKD is more than 3 months. Is anuria contraindication for renal biopsy? No, it's not. Unexplained anuria. So anuria, actually. So when you have a patient who's suddenly anuric, 2 things that you need to think of has the patient suddenly become obstructed? So either it could be bladder outlet obstruction or obstruction of a single kidney, right? Otherwise, there's no reason for a patient who has been passing urine to suddenly not pass urine, right? The other thing you need to think of is it a sudden vascular insult, right? So like a dissection or, a clot, some sort of thrombosis affecting both renal arteries. It's only in those instances that you will get sudden anuria. Then, of course, you can get anuria if you have a kidney disease or any cause of AKI, which is severe, but that won't happen immediately. It will happen over some time. And then, your indications are basically the same. So if you need to find the diagnosis and if it's going to change the management. What is the role of Kakeri in urolithiasis? That I don't know, actually. I haven't heard about it. Any changes in references in management in pregnancy, post-op AKI without hypovolemia? So AKI in pregnancy is a separate topic, right? So there are different conditions that can cause AKI in pregnancy. And then you have to worry about you have to worry about the fetus. So your management strategies differ. The drugs that you can use are different, right? And when it comes to renal replacement therapy in pregnancy, we have different cutoffs. So usually we cutoffs in the sense we actually do have cutoffs in pregnancy. So we would start dialysis at lower levels of blood urea. So blood urea of about 50, just to maintain, to reduce fetal toxicity, right? But that is actually more in CKD, patients with CKD going on into pregnancy. AKI developing in pregnancy, there isn't a lot of guidance on how to dialyze. Probably you would dialyze them in a similar way. And probably if someone is getting AKI in pregnancy, there's something else very severe going on, which would need specific management. So could you tell again about the UFR in AKI versus CKD? So you can't differentiate AKI from CKD from a UFR, right? But if there is active disease, an active sediment, so say you have lots of proteins, you have lots of red cells, then you may be more worried that there's some acute process going on. But you can get red cells, you can get casts, you can get pus cells, protein, even in chronic kidney disease. Right? So what is going to determine whether this is AKI or CKD is your other factors, your history, how long has this been going on for, and the other features like that. In the presence of diuretic effect, how to identify the polyuric phase in recovery? Yeah, so what we do is, so often that's a very common problem. So we start the patient on some furosemide and then the patient starts passing a lot of urine. So then you need to stop the furosemide and then see what happens. Okay, so I think we've covered all the questions. Know if anybody from the SLMA is here. If there are no more questions, I think we can finish the session. One question. Can we use furosemide just to improve the urine output if no evidence of overload in AKI? So I don't think there's any point in doing that because it is not a treatment for acute kidney injury, right? And it is not a treatment, and it may even reduce, like, it can cause hypovolemia. So we are worried about renal perfusion in AKI. So if we have any concerns about the volume status of the patient, then we are just making that worse by giving the patient furosemide. So no, we don't use furosemide just to improve the urine output. It could, I suppose one instance would be if you have to give the patient some volume. So say if you need to give the patient blood, then you would give it. But again, that's in the setting of expected overload. So no, otherwise there's no real place for furosemide. What's the difference between creatinine and blood urea? So blood urea, the thing about blood urea is that there are many things that affect the blood urea, right? So dehydration itself without, real significant acute kidney injury can make the blood urea go up, as an example, right? So usually, then I'm sure you know that, say, GI bleeds can make blood urea go up. So creatinine is a better way of estimating the kidney function. And one place that blood urea is useful is, say, where in patients with rhabdomyolysis, where the rhabdomyolysis itself can make the creatinine go up without an associated kidney injury. Then looking at a blood urea and seeing that is normal could be reassuring. But otherwise, we don't generally measure it. But having said that, when it comes to sort of correlating the uremic symptoms and signs, it's easier to correlate it with blood urea than with creatinine. And in pregnancy, again, we correlate it with blood urea. When do we take a patient with AKI to the ICU? So the ICU becomes important mainly when they need CRRT, continuous renal replacement therapy. So, that is when patients are hemodynamically unstable. So it's like you book an ICU bed for a patient who needs intubation. Similarly, if we think a patient is going to need CRRT, that also would, I think, be a reasonable reason to book an ICU bed. But the difference is that in the ICU, you may only have one CRRT machine, which if it's attached to one patient, nobody else can use that machine, right? Because it's continuous renal replacement therapy. So there are problems with resources like that. Any other questions?
Dilushi, have you finished?
Yes.
All right. Okay. So I'd like to thank Dilushi for that excellent lecture. You were kind enough to answer many questions as possible. So the message for the participants are like, next time we will try to do a long case, if possible, either in surgery or gen ops. So that will mimic a scenario very close to your exam situation. So with that thought, again, thanking Dilushi. We hope to meet all the participants next time. Thank you.
Thank you.